everyone for coming to the Staff for Kids presentation today. I'm Judith. I'm from one of the providers within the Staff for Kids program, and to my left, to the right, is Katrina. She's also one of the subcontractors. We're going to share this presentation because we both love public speaking so much. Okay. I've got to do it myself. Oh my gosh, I've got to do my own work. Oh, okay, no back. Okay, so the objectives of the Staff for Kids program. Sorry, I just want to go back and actually say that Staff for Kids is supporting classes off children or them to achieve resilience. Someone wants to get me on my phone, right. Okay, so the objectives are, well, it replaced the ATAPS program, which finished in June. A lot of you may know of that program. It is now replaced with Staff for Kids, and it's the PHN, the Primary Health Network's responsibility to the Department of Health to increase effectiveness of medical services for clients with poor health outcomes, and this of course includes children, very importantly. So we want to need evidence-based psychological strategies, and the objectives are to help children aged 3 to 12 years at risk of developing a mental, emotional or behavioural disorder. We want to improve availability and accessibility to psychological treatment for children and their guardians, and we want to increase tailored intervention for those same children and guardians. So who are the providers? Okay, so for Campbelltown, Camden, me, under my business, which is the Sparrow Centre for Children, for Wallandilly and Wingecarribee, it's Katrina, which is at full potential. And in Bankstown, Liverpool, it's Mission Australia, and also, not on here because we weren't aware until this morning, that in Fairfield is an organisation called the Proactive Psychological Practice. So they're the providers that hold the contracts for all the LGAs within the PHN area. Okay, you can do the next one. Okay, so we are meeting local needs. What does that mean? Well, for me, children who often need the most help don't get it. I've worked in community services for 25 years, and consistently we see families and children who don't get the services they need. They don't get it quickly, as Ian was saying, and they don't get it in ways that often suit the family. So disadvantaged communities face complex challenges and multiple disadvantages, and what often is easy for us is not easy for them. So children and families that are experiencing multiple disadvantages, such as poor housing, poor food security, English as a second language, medical conditions, and reliance on what is often a fragmented public transport system, simply don't access services in the same way that everybody else does. So what happens? Well, children are often more likely to be excluded from school, they have less educational attainment, they have less social networks, and they have more trouble with the police. We have experienced increased numbers in adverse events and high levels of mental health concerns. If we look at the Adverse Childhood Experiences study, we can see that there's a link between the number of adverse events in a childhood, a child's early years, and social emotional functioning later, which then links to increased risky health behaviours and ultimately can lead to mental health conditions. So getting in early is really important. The other thing is that families that are less likely to use services that do not fit into their daily routine, and they are not easy to get to or don't fit with their values. So if you're not with families in the community, with the community, there is less service uptake. This is something consistently seen in socially disadvantaged communities. So Staff for Kids is focused on increasing service access from underrepresented groups, such as Indigenous, culturally and linguistically diverse groups, lower socio-economic groups, families in crisis, and those residing in rural and semi-rural areas. Innovation, okay, something I love. So we need to be in the community, getting out into the community. One of the objectives, I think, of all of the subcontractors is to be with people, to find children who don't access services and to provide innovative and accessible services. We want to bring private practitioners together with community service organisations and get people out into the local areas where the disadvantage is. This means leaving our office, going to the community. For me recently, I've started accessing and providing services for clients at Tharrawal. So I'm not in my office, I'm out in the community. I've recently had contact from schools, again, so has Katrina. We're not in our office, we're out in the community. The other thing we're doing is a diversity of interventions, not just talk therapies. We're with children, and children don't always have the cognitive capacity to actually talk as adults do. So we're doing things like TheraPlay, trust-based relational intervention, and child interaction therapies, where I know for me, I love working with younger children and families in helping them with attachment and bonding and those things that really help to build good social and emotional bonds and resilience in kids. And we want to promote mental health services into hard to reach communities, as I've said. Okay, I'm going to hand over to Katrina.
Thank you. Okay, I just wanted to have a look at the evidence, and what we've found is that early intervention in children, it's imperative to be able to address the emerging mental illness, which can have an enduring consequence if it's left unresolved. So adversely affects areas such as their ability to be at school, to function at school, to develop at school, to learn, and also then the social impacts that it has later in life for them. So the stepped care model that some of you will have already seen in some of the brochures has the low intensity down here for the new access, and then we have the medium intensity here, and this is where staff for kids, so what we're talking about right now is sitting here in the medium intensity. And then of course you've got your high intensity and your severe and complex, but we're sitting right here. Okay, now who can be eligible? What we're looking at is children aged 3 to 12. We're looking at if they have any sort of signs or symptoms of an emerging mental disorder, which is causing some sort of dysfunction in their everyday life. We're also looking at we're looking at children who are at risk of developing a mental disorder if they have one or more symptoms, social, emotional, behavioural, or where a child's developmental pathway is considered to be disrupted by their mental health condition. You can either be referred by a paediatrician, by your GP, by a psychiatrist, or any of the PHN identified referrers. So at the moment we're looking at things like at schools, school counsellors, principals, things like that. The child has a mental health treatment plan, but I'll talk about that in another slide in a moment. And also they must have the guardian's consent. Now the out-of-scope services, so the things that we won't be doing, is the services that are targeted at developmental or learning issues. We're only really looking at the emotional, the behavioural difficulties. And in saying that, sometimes when you have a developmental or learning issue, you also then have some sort of emotional behavioural difficulties. But that's where we're focusing. Treatment services for guardians, which are primarily focused at the guardian's mental health, that's not what Staff for Kids is about. It's only for those children 3 to 12. And we don't want to be duplicating or doing any sort of services that are already being done somewhere else or in another way. So services which would be provided through better access to psychiatrists or psychologists and the GP initiative is not what Staff for Kids is about. This is more complementary to that. Okay, now the people who can provide this treatment are psychologists, mental health social workers, accredited mental health nurses, mental health accredited occupational therapists, and mental health accredited at-sea health workers. So for the referring process, there is the option for 3 sessions prior to the GP mental health plan. It's more of a provisional sessions that are allowed, and then after those, then a GP mental health care plan would be required for the child to have. They can also just go and get that right at the beginning. So there's just that avenue there, just in case, say, a principal was to refer a child and is unsure, then that is where those sessions can be used to be able to then determine whether a GP mental health care plan would be required. Referrals are sent, they're all sent to the PHN centralised intake clinician, and then they get allocated a certain amount of hours for each client. The maximum treatment hours are 12. There is a referral form that is required, and I think that's a little bit different. If the GP refers them, then it's one particular form. If it's a school, it's a different form. Very similar, just a little bit different. And then the mental health care plan for them to access all of those further hours. What the treating professionals need to do is they need to ensure that the guardian, so the parent or the carer, fills out what's called a Strengths and Difficulties Questionnaire. We routinely have been doing them for a long time now, but this is part of this process. You need to do it at the beginning and you need to do it at the end. So as we've been hearing earlier today, we want to be able to measure that there is actually some sort of improvement happening for these young children. We need to also collect the guardian satisfaction survey to make sure that it's meeting their satisfactory needs as well. As providers, we need to be ensuring a high quality evidence-based service, and we need to also be providing crisis support if it's available, and that's where that stepped care model can come into play. So to ensure the transition pathways are in place for clients to move between those different services, so that model that you saw before, which was the low intensity, medium, moderate and severe, and be able to move as we heard in the previous talk. Okay. Now I've put you all to sleep. Does anyone have any questions? No? I've put you to sleep. Oh, yes!
So with the 12 sessions, is that per year or is that under this program?
As far as I'm aware, it's for the year.
The calendar year.
A calendar year.
Sorry, if they've already had 3 sessions because they've been referred by a school principal,
Yes.
they can have another 12
No,
after that?
no, those 3 are part of the 12. Yes?
Yep.
And if they need something else after that, like if the situation's not resolved after 12, what would you do?
We would be looking then for the free to stepped care model, and we'd be looking at then what other avenues are for them. But we actually come across this in other facets as well, where you run out of sessions. So we're always looking at what to do next, what other thing can we work with, and that's what this whole model is about. It's working with other services to be able to complement and make sure that they're just not left.
The target is really for those kind of conditions that respond to that brief intervention. So if it doesn't, then you would be looking at accessing other services. As Katrina was saying, we have another steps.
An example might be then to be working within the school, or working with a school counsellor in the schools to be able to take on and keep the momentum and work for that child. But there's other services as well that would be brought in.
Probably ICANN's local health district.
They might require a better access plan too, back when they've used their better access plan.
You can't use both. There.
No.
Sorry, Katrina.
It's an issue for disadvantaged communities, because if you can't pay,
That's
yeah,
right.
where do you get linked to,
Yeah,
and
that's
how
what
do
worries
you
me. Yeah.
continue? Yeah, yeah.
So they can't then access, they've only got one plan, so if you use the 12 sessions there, then they're kind of lost for the rest of the year.
Yeah, it's tough. It's tough. Yeah. And I know for me, I've done a lot of pro bono. I think a lot of psychologists actually do a lot of free work.
When you were talking about working in community, what sort of things are you doing?
In community, well, we're working towards providing the services in the community. I know for me as a provider, I'm looking at doing very parent-based work. So, you know, when I don't just see a child, I'll see the parent-child interaction type attachment-based work is what I'm really keen to do, because it predicts so much, having that really healthy relationship. And socially disadvantaged communities often really struggle with that. Yeah. So that's the sort of thing I'm doing. I'm doing a little bit of, I guess, teaching parents how to. I'm a play therapist. I like to say I'm a play therapist first and a psychologist second. And I like to teach parents how to help their children learn to play, because children don't intuitively know how to play all the time, and often we need to help parents teach their children and to be alongside their children in that process. So having a little bit of play-based engagement is also what I'm looking at doing. Yeah. And maybe being in community centres. We're working on that at the moment. We're new. Yeah.
Is there any groups for children in your program?
Not in my program, no.
Yes, there is in ours. So, yes. And to answer, I just heard from Anne that one of the suggestions was that the adult can go in and get their own mental health care plan as well, so that entitles them to another 12 sessions. So there's sort of a ways around it as well.
Yeah, a lot of families don't know that, but it's true.
Yeah, so it's a good point.
Someone else?
You have clarified this already, but when you say that you're working in community, do you mean you're accessing families in community centres, or you're going to...
Wanting to be in community centres at the schools as much as we can. So when I'm looking to subcontract, and Katrina is the same, I think you have a social, mental health social worker. So we want it, and homes, you know, going to homes. I don't provide that right now, but it's certainly something that's possible for me, yeah.
Yeah, we are currently going into the community centres and going into homes as well. As long as the risk is minimised, what we would normally have is 2 people going in to the home, at least for the first few times anyway. So yeah, that has been happening and it will continue to happen.
I know for me, I have a mobile play therapy kit. I have a room that's a play therapy room at my Queen Street office, but I also have a kit that I can get out and about with. As well. It's just establishing the connections and the facilities to be able to provide what we need to do. Yeah.
Sorry, one more question. So do you also then access, do you work within school hubs? Are you accessing schools via some of these school hubs, community hubs?
I'm not in schools as yet. I was approached last week to provide services in a local school. And those discussions are underway, how we will do that, and have a partnership around that. Yeah.
Can I add to that too? We're doing a trial. We're targeting Fairfield at the moment, so we're looking at some schools there and offering groups through the school counsellors there as a trial, and then based on that, we may then roll that out. So it's a work in progress.